Hello, good morning. This is Dr. Centeno. Thanks so much for joining me today. Today, I've got another interesting topic. Can ligaments heal naturally? And can CCI heal itself? Now, this one kind of came up because I had a patient ping me about this because there was some talk of if you offloaded the craniocervical junction, let's say with curve restoration, that those ligaments would heal naturally over time. Or another example of this would be if you were to use a cervical collar and just stopped loading the ligaments altogether, that the ligament would heal naturally. And this applies to lots of different things. So that would include things like a partial tear of your MCL or a partial tear of your ACL or other ligaments in the body. So the goal today is to go through that, try to see what the evidence is or isn't that ligaments that really fail that first healing bite at the apple can heal naturally on their own. So that's really what I'm talking about here. The concept is that you get a ligament injury, let's say to your craniocervical junction, that doesn't heal in the expected acute time frame, right? Within the patient noticing that they're dramatically better within the first month or two, and then by 3 months they're feeling like 90% better, and then slowly over that next 6 months everything resolves. These are patients that don't get that full heal out of the gate. So that's what we're going to discuss today. Again, if you're just joining us, we're talking about whether ligaments can heal naturally, because this was brought up by a patient this week, and I hadn't really ever covered this topic in depth. The goal today is to focus on patients who get a ligament injury, like to their craniocervical junction, and that first bite of the healing apple fails, right? They end up with a ligament that's not fully healed. So if we were to take pressure off of that ligament and loading off of that ligament, would it eventually heal on its own? And what does the science say about that? And then we'll get into extensive Q&A. As I always say, if you want to get your question answered, then put it in the comments, and I will obviously get to those questions in the order in which I see them. Now, the problem usually is by the time I get, let's say, 40 minutes into the hour, we start to see more questions than I can possibly answer within that hour. So please take some time and ask about this topic, ask about any topic, and get your questions in the comments so that I can get to them before all of this is done, because I really want to answer everyone's question. So let's start today with, again, can ligaments heal naturally? And then we'll go into extensive Q&A after that. So let's dive in here. So these are the citations or the scientific references to peer-reviewed articles that support what it is we're going to be talking about today. So this isn't just my opinion. This is sort of the peer-reviewed consensus of what's out there on ligament healing. And as I stated before, the major question we're trying to answer today is if you reduce loading on a ligament, will it eventually heal on its own? And we're talking again about ligaments that fail that first bite at the healing apple. So you get one bite at the healing apple. If it doesn't work, you're left with a ligament that's not fully functional. It's stretched out and it's got micro tears or some other problem with it, but it's not functioning as normal because it's too loose. And if we were to take the weight off of or the force off of that ligament in some way, could it heal on its own? And if so, what does that healing look like? So let's first go over what really prevents a ligament from healing at all. And that's going to be when there's a large gap. So the first thing is that a ligament is torn back and retracted with a large gap there. like if you cut a rubber band. Now, most of the ligaments we treat, well, almost every ligament we treat with regard to craniocervical instability is not like that. There's no evidence on the imaging that the ligament has cut in half and is retracted back. Instead, the ligament is stretched out and it's not doing what it's supposed to do. And then a second thing that can prevent the ligament from healing, and that's really appropriate for craniocervical instability, is ongoing joint instability can keep the tissue from maturing well. And all that means is the joint is chronically unstable. In this case, the craniocervical junction, but it could be the knee. And that instability keeps damaging the ligament itself so that the ligament never gets a chance to heal. And then there's the healing environment, right? We see this in a lot of our patients who have things like MCAS or who have other exposures that are causing chronic systemic inflammation, really inhibiting the healing process. And then another thing would be sort of repeated traumas to that ligament. And a lot of our patients have that issue. The trauma may not be a lot. Let's say they're getting out of a car they're not familiar with and they hit their head on the side of the car there, and then that sets them back. Or they are doing their normal activities, but it's winter and they have a slip and fall, and normally that slip and fall really wouldn't damage much, but it sets them back. So these are all the things that can limit long-term healing of ligaments. Now, how can a ligament keep changing, or what happens inside a ligament for repair? So there are repair cells within the ligament that continue to work over time. These are progenitor cells. Progenitor just means that they are cells that can facilitate repair and then turn into the type of cell required. So in this case, the type of cell required would be a mature ligament cell or a ligamentocyte. Having said that, many of these are either direct ligament cell progenitors or mesenchymal stem cells within the tissue, and that's what those guys do. And then these cells make, remove, and reorganize collagen. Now, when it says these cells, this is purposely keeping it very simple, but for example, macrophages are sort of the garbage men, right? After an injury, they come in and they take out the garbage. They do the deconstruction and take out the junk so that something can come in and repair that area. And then over time, so you initially get the acute inflammation phase where all of that happens. You've got repair cells coming in. You've got macrophages taking out the garbage, if you will, and doing some demolition on the damaged area. Then you've got cells that come in and lay down new tissue. But then finally, over time, those collagen fibers have to be loaded because they've got to know how much stress they need and they've got to get stronger. So that's what happens over time. We see maturation of the tissue where it gets stronger, or reorganization of the tissue. And so realize that this isn't a static process, right? It just doesn't happen over a couple of weeks. The tissue continues to mature as it determines how much load your body requires of it. So let's get into this concept, right? What does the research say about can ligaments keep healing after the first year? So ligaments usually heal the fastest in the first 6 to 12 months. Most of that is probably for most young people within the first 6 months. As you get older, it can stretch out into 9 or 12 months. But healing and remodeling are going to slow down after that. And really, when this is when we fail that first bite at the healing apple, right? The ligament didn't fully heal. Instead, you get some scar formation, and then the scar remodels. So the best evidence we have from this is from medial collateral ligament in the knee. But what it kind of shows is that ultimately the tissue that you end up with, if you fail that first healing bite at the apple, meaning if it's not fully healed after that first, let's say 3 to 6 months, or mostly fully healed, it's going to really just be remodeling a scar. So you're not going to get full ligament strength that way in most instances. So again, just to review, we've got injury inflammation, we've got tissue inflammation, and then we have remodeling. So those are the 3 different phases that we're discussing here. Now, does the healing stop after that first 6 to 12 months? Again, it doesn't. It does continue, but it continues at a slower pace. So as it says here, late improvement is usually remodeling of scar tissue and not creation of brand new normal ligament tissue. And that's sort of the seminal problem when these ligaments don't heal out of the gate, is that they go into this chronic healing mode where your body's trying to make it as strong as it can, but it's kind of working with its hands tied behind its back because it's trying to remodel a scar rather than build new tissue. So again, when this is studied in animals, so here we've got a rabbit model, ligament tissue kept changing for 1 to 2.5 years after the injury. The good news is that the researchers showed that collagen fibers became more organized over time. But even with improvement, the healed tissue often stayed different and basically less capable than the normal ligament. So again, this applies only when you fail that first bite at the healing apple. And then it kind of goes into chronic remodeling stage. You're basically remodeling scar and you're not getting the same strength of ligament. So again, you're not really getting a fully formed and capable ligament at the end of that process. So the conundrum of ligament healing is this: taking load away, so let's say putting on a cervical collar, will promote some healing, right? Because you're reducing load, you're allowing that ligament to heal. But if that ligament didn't heal on its own initially, what that is going to get you is a ligament that's not as strong as it should be. It's also going to get you, as I've often talked about with a cervical collar, it's also going to get you quite a bit of upper cervical muscle atrophy. And then you're going to have more instability because you've worn that collar for a long time and now the muscles can't support your head. The conundrum is, for this to work in that first acute phase of a ligament injury, is that you need to load the ligament soon after injury. That's in fact a key portion of healing the ligament that we'll go into here. So we've got this duality, right? On the one hand, you need to load the ligament to get a normal ligament because your body needs to know what those demands are. On the other hand, if you try to do too little with the ligament, yes, that'll promote some healing like a cervical collar, but ultimately it's going to damage the long-term healing process. Or like in regenerative medicine, you can provoke a new minor injury or kick off another healing cycle and get another bite at that healing apple and then gradually reload that ligament. And let's get into this because this is so important for ligament healing. And that is that too little activity is going to slow the recovery of that ligament towards normal. Too much strain on the ligament or too much pull or loading can keep the tissue irritated and unstable and unable to fully heal. So when I talk about threading the needle, this is what I mean. In order to get a normal amount of stability out of that ligament, you've got to thread the needle between loading it, but not pissing it off. And this is really critical, right? Because what happens in many CCI patients is they'll get their initial injury and then it doesn't fully heal. And they get into this spiral where movement causes problems. So then they don't move. But by not moving, they are in fact hurting their ligament healing. Now, in many of those patients, we need to provoke another bite at that healing apple. And then once we provoke another bite at that healing apple, they can then do this graduated increase in movement. So it sort of resets the clock. So the key take-home message is that if you're young, you're probably going to fully heal your ligament in about 6 months. If you're older, it might take up to 12 months. And you'll get slow remodeling after the ligament heals or does its best to heal, but you're mostly remodeling scar tissue. And in order for a ligament to fully heal, you've got to thread that needle between activity that promotes loading so that your body knows how much ligament tissue to put there, but not pissing it off. So ultimately, really the answer for many of these patients that find themselves with a not fully healed ligament comes down to regen med. So this is the data on PRP and bone marrow concentrate that shows that those types of injections into a ligament can promote healing of that ligament or give the patient another bite at that healing apple, which is really the critical part here for a ligament that doesn't fully heal. So this is why we use regen med, right? You get one bite at the healing apple. If that doesn't work, this gives you a second bite at that healing apple. And you can try to offload the ligament if it doesn't heal. That's conservative care before injections. And maybe it heals, but in many patients, it kind of heals not fully strong. And hence the best move in that kind of situation where someone is still functionally disabled, their ligament hasn't fully healed despite offloading it and everything else and trying to thread that needle, then you've got to reawaken those healing processes and start that process over, which would be regenerative medicine. Okay, guys, I think that's all I've got here for that. Let me go and get rid of that. Okay, let's start taking questions. Lots of questions coming in. Again, if you want to get your question answered, put it in the comments, whether you're on YouTube or Facebook. Realize that I'll answer these in the order in which they are received. They don't have to be about what we're talking about, but oftentimes there are more questions than I have time to answer. So try to get them in now. Let's see. Casey and the Reds, who read a lot of DMX, don't include ADI, CXA, or Grab Oaks info. Any idea why? Can you teach me how to do these if not included? Yeah, Casey, and generally DMX, well, let's break that down, right? DMX is a good way to look for atlantodental interspace, which is the distance between the atlas and the dens as you look down. It's not a great way to measure CXA or Grab Oaks because there's too many overlapping shadows. The best way to measure those would be on an imaging technology that has slices. That's going to be a CT scan or an upright MRI reflection extension. I'm not a big fan of CTs. CBCTs with flexion extension are not bad, but they also limit the amount of flexion extension. So they're going to reduce the ability to detect what's really there. So again, ADI, I've got videos on that can show you how to measure an ADI. That's pretty easy. But CXA and Grab Oaks, not a great match for DMX as an imaging technology. Vera, Dr. C, could apparent tennis elbow or elbow pain inform painful tightness be caused by either CCI or lower neck issues instead? Yeah, so usually that's a lower neck issue that causes that. And it's very, very common in all patients that have any lower neck issues. Now, is it possible that CCI itself could cause it? It is, but less likely. Usually it's a lower neck irritated nerve those nerves go to these muscles here. And as those muscles misfire, they pull on the bony end where they attach, which is at that elbow. So you get things like medial epicondylitis, lateral epicondylitis. Jennifer Jean. Hi, Doc. Big fan of yours. I'm always poking in your lives. I've recently found out that I have bone marrow edema at C2. It's minimal now, but I worry about instability as I've had 2 spine surgeries in that area with Chiari surgeries. Yeah, Jennifer, I think what you bring up is an important concept, right? One of the things that's not always read out on imaging by the reading radiologist is when there's swelling in the bone. Many times they will, sometimes they don't. And the reason why swelling in the bone is important is it really just means the bone is getting beat up or it's not healthy for another reason. Usually the bone is getting beaten up. And so it's a great bit of circumstantial evidence that allows you to say, aha, there's something going on here where this bone's getting beaten up. So if you were in a situation where you had had 2 previous spine surgeries, let's say a Chiari decompression, that's going to facilitate or increase instability, and you've got pain and disability, and you have bone marrow edema in the C2, then that's circumstantial evidence for instability there. So we would then need to go and do movement-based imaging to see if CCI is present. Ryan, hey, Dr. Centeno, what's the best imaging for the thoracic spine to check, see if any problems are coming from that area on top of having CCI? Yeah, Ryan, usually it's just a standard thoracic MRI. It doesn't really need to be weighted. Thoracic MRIs are tricky because MRI as a technology really doesn't like movement. What do you have in the thoracic spine, right? You've got a beating heart, you've got moving lungs. So I would go, instead of an upright MRI, which is going to have low field strength and really struggle with that movement, I would go with a closed bore MRI, a thoracic MRI. Doesn't have to be anything special, but at least a 1.5 or 3 Tesla magnet. And then you're really looking for a bunch of different things there. You're looking for a disc bulge. You're looking for arthritis in the facet joints. You're looking for arthritis in the joints where the rib meets the spine, or costovertebral joints, or costotransverse joints. You're looking for atrophy at that level of the stabilizing muscle. So all of those things can give you some nice data along with a hands-on exam that there's something separate going on in the thoracic spine that needs to be treated. And then the problem is many interventional pain doctors don't like treating the thoracic spine because the lung field is there and it's more technically demanding. Now, I've done thousands and thousands of injections there. I feel very comfortable with it, but many interventional spine guys don't like it because of those issues. Elizabeth, Roxanne, I'll be having an EPICL done. I'm curious about adding the jaw. When it comes to injecting the jaw, what structures, muscles, ligaments, actual disc can you inject, and what do you most often inject? Yeah, Elizabeth, so we frequently add the jaw in on an EPICL procedure. The reason we do that is that often the jaw is involved in trying to stabilize the head on the neck, and that causes pain within the jaw, degeneration, etc. Now, we can inject lots of different things there. Usually I'm injecting inside the joint, which includes the disc. I'm injecting the ligaments in that area, plus the connecting muscles, i.e. the temporalis, etc. Because frequently the temporalis tendon will be quite aggravated. So yes, it's pretty easy to add. We do it all the time for our EPICL patients. Casein, unusual for overhangs at 7.4 and 6.8 in patients with only mild trauma history and no obvious hypermobility syndromes. Yeah, the first thing I would say, Casein, is we need to be a little careful with some of the DMX values that we see, right? As we've taken DMX in-house for select patients, I would say 90% of our DMXs are still done around the country. But as we've taken those in-house and we put a radiographic ruler in the field so we know exactly what the measurements are, what I've seen is that those measurements have collapsed a bit. And I think what happens is that if the DMX center doesn't use a radiographic ruler in the field and calibrate on that measurement, they're literally relying on somebody way back that calibrated the distances for the DMX machine that have probably gotten a bit off. So the first thing is most DMX overhangs I see that are reported in the 7 range aren't in the 7 range. So that's the first thing. Assuming they are in the 7 range, again, is it unusual? Not unusual. I will just say that those would be sort of in the mid-range of DMX overhangs that are abnormal that we see, and not a concern for treatment response. But again, unusual, not unusual, they wouldn't be unusual. Carol submitted advanced by Elizabeth Sands. Does what you eat affect healing? And if so, what type of diet is recommended? Yeah, Elizabeth, I think the biggest single thing that Americans, at least, get involved in is a high glycemic diet that has all sorts of nasty oils. So, for example, you go to Starbucks, right? Used to be you just got a cup of coffee, you were good, you left. But there's a reason why Starbucks serves pastries and not steaks, because caffeine for about half the population can really mess with your blood sugar, and you get that blood sugar spike and then it crashes, and then you want more sugar. Now that's called hyperinsulinism or metabolic syndrome, and it's super common in the United States. It's one of the major reasons why Americans have gotten so heavy. Another thing going on would be, all the processed foods, the crazy oils that are put in those processed foods. So if you're looking for a diet that's going to optimize healing, the first thing you got to do is get rid of the sugar, because you don't want those blood sugar spikes while you're trying to heal. That's counterproductive. That's called a metabolic syndrome, and it reduces your body's ability to heal and causes chronic inflammation. Same thing with all these processed foods and the unnatural components that are in them. So you would trend towards eating organic, not stuff that is pesticides that's been used. You would trend away from some of the crazy seed oils, for example. Canola oil being a great example. It's rapeseed oil, not good, towards more natural oils, avocado oil, olive oil, etc. And so that's the kind of diet you would pursue to try to optimize healing, reducing blood sugar spikes, and trying to get rid of some of the things that could be causing chronic inflammation in your diet. Lindsay from Utah, what can we do if CCI has triggered nonstop MCAS flare? How can we get MCAS under control so our ligaments can heal? Yeah, it's a little bit of a chicken and the egg dilemma right there, Lindsay. On the one hand, if you've got CCI irritating the vagus nerve, and that's affecting your immune system, and that's causing some MCAS, then you really got to get rid of the CCI for that to go back and help. Now, you could try to heal the CCI with things like a cervical collar, curve correction, etc. And if that reduces the beat up on the vagus nerve, maybe that interrupts the cycle. So that's something to start with as a treatment strategy. Having said that, if that doesn't work, then probably not a great idea to try to let the ligaments heal in the presence of MCAS, because that's causing too much systemic inflammation and too many problems to overcome. So it comes right back to getting the CCI treated. Hey everyone, if you're here, thank you for being here. I appreciate everyone here. I'm gratitude that you guys all show up on a Sunday morning to do this. But what I'd like you to do is to give me a like where you are or subscribe, because that's how people find this content. And we want lots and lots of people joining us asking good questions, getting their mindset at ease. But that doesn't happen, regrettably, with the algorithms unless you like this content. So please pay it forward to the CCI community and do that if you haven't yet. Cassian, any differences in PICL outcomes for type 1 diabetics? Any post-treatment differences in this population? You know, we don't have a lot of type 1 diabetics in our treatment population. So that one I couldn't answer. I would say that our current treatment population, based on what I see, has much, much less than 1%, probably 0.1% of patients who would be type 1 diabetics. So that's one I don't think I can answer. Now, I can tell you speculatively what might happen, right? In type 1 diabetics, you're going to have that blood sugar out of control, just like I was talking about. And that is going to cause chronic inflammation, and that is going to cause an inability to heal. That's well known. We know that type 1 diabetics have a hard time healing for those reasons. We know that type 1 diabetics, for example, are more likely to get a post-op infection for those reasons. So that's the best I can say there, is there'll probably be some inhibited healing, but we don't have enough in the data set now for me to really opine what percentage difference that might be, or is it even clinically noticeable. Greg, I remember you speaking of the donut hole. Is this dip and increase in symptoms for some after initial tightening after PICL? If many dip around the 3-month mark and feel better month 5 to 6. Yeah, so Greg, what I've talked about before, first let's back up. What is Greg talking about with the donut hole? The donut hole in ligament healing, especially many of my CCI patients, is they do really well in the initial acute inflammatory phase because the inflammation is tightening the ligaments, so they're more stable. Then that inflammation goes down and they get into that long-term remodeling phase eventually. In the middle of those two events, you can feel worse before you feel better. Now, for most patients, it's much quicker than what's being described. Usually the donut hole will be after the first 3 or 4 weeks, and then they'll be out of the donut hole by month 3. But in patients with chronic systemic inflammation, which is only about 20-25% of the patients we see, they get pushed out on the donut hole because that chronic inflammation doesn't allow that acute inflammation to go down so quickly as it does in a normal patient. So they see what Greg's talking about, a dip around the 3-month mark, and then they feel better about around month 5 or 6. But if that's what's happening with your donut hole, if it gets pushed out that far, you know you're in systemic inflammation land. That's what's causing that. So you should be looking at all the things in your life that are causing that systemic inflammation. Diet, as we've talked about, maybe it's an MCAS component, all of those things. Hi, Dr. C, what's the best predictor of more than one EPICL? Yeah, the best predictor that I found so far is to be out of that first year window after your injury. So for example, when we see patients that are 6 months injured, it's more likely that they're going to have a one and done. But if I see a patient that's 4 years out from injury, it becomes much less likely that they're going to be a one and done. So it's the amount of time since the initial injury. Now, why is that? It's likely because we're getting some damage of specific structures with the instability over time. So if you've only had this for 6 months, not much time yet for things to be damaged by the instability. If you've had it for 4 years, much more time for structures to get damaged by the instability that then lead to symptoms. Are you really live? I am really live. Let's see, it is 9:35 a.m. here, Mountain Time in Colorado. I'm so lost. It was confirmed via flexion extension X-ray 2 millimeters movement or anterolisthesis of 2-on-3 through 6-on-7, and the damn doctors won't help. I've got severe neck pain and dizziness. Yeah, so if you have flexion extension with issues at 2-3, So the first thing you need to know is the tolerances for translation. In a flexion extension x-ray, you're looking for one of the vertebrae to slide forward on the other or backwards. That's called translation. An anterolisthesis just means that the one vertebra is moving forward on the other. So if that's at 2-3, C2 is moving forward of C3 in flexion. And it sounds like you've got that stair step thing going on. Maybe there's some issues at 3, 4, 4, 5, 5, 6, 6, 7. Now, the tolerances at C2-3 are much, much smaller. So 2 millimeters at C2-3 would be abnormal, whereas 2 millimeters at another level, let's say C4-5, is probably not necessarily distinctly abnormal. Then you back up and say dizziness in folks with neck pain who have issues in the neck relates to the upper cervical spine. So C2-3, C1-2, C0, C1. So now we're in a situation where, as a specialist in this area, I'm saying, okay, we've got extra motion at 2-3 confirmed. We've got dizziness, which we know can come from 2-3. So now we're going to start to focus our treatment on that 2-3. And we're also going to need to go back and get some other types of imaging, like a DMX or an upright MRI with flexion extension, because we're going to want to rule out other kinds of CCI as well. But we would call that a type 3A CCI, all things being equal. Again, that's in patients who have that, not your specific case, because I don't know all your specific details. Casey, do keloid formers heal poorly compared to those who don't, either native healing or in regen procedures? You know, Casey, and that's a great question. I don't know if keloid formation in the skin would translate into poor ligament healing. That's one I'd have to look up to really dig into. So I don't know the answer to that one offhand. Hugh Games, ringing in ears, pain in traps and base of skull, eye issues, etc., but everything allegedly is normal. Yeah, so again, if you're talking about a neck injury, patients that have ringing in their ears and base of skull problems generally have an upper neck issue. So that's the first thing to be looking at. If the MRI is normal, then you want to pursue, or patients like that would want to pursue movement-based imaging, DMX, upright MRI with flexion extension, to try to make sure that there's no instability in the upper neck that would relate to things like the tinnitus you're discussing and the base of skull pain and the vision issues. Now, those can be caused by lots of other things, right? Those have to be ruled out. But when it comes to your neck, those are upper neck issues. Vero, what are some of the factors that would cause ligament not to heal in the initial phase after injury? What kind of mistake do people make? Yeah, Vero, I think we went over those, but probably a good thing to go over again. Let me share that so you can see it here. So what can limit long-term healing, right? A large gap or poor ligament, basically a ligament that's got a large gap and is pulled back like a rubber band. 99.9% of my CCI patients don't have that. Ongoing joint instability, when something is very unstable and the area keeps getting injured, the ligament keeps getting injured, that can also prevent natural healing. The healing environment, we've been talking about MCAS, chronic systemic inflammation, and then repeated injury, right? We see patients like that. Let's say they're 2 months into their ligaments healing, they're doing pretty good. It's winter and they slip on a sidewalk. So that's what that means. So those are all the reasons why ligaments don't initially heal. So let me pull that down now. How can I know if a ligament healed well? Yeah, so the answer is you've got to test for instability. So you want to give it at least a number of months, depending on your age. Let's say on the outside, 6, because you'll see firming up of the ligament within 3 to 6 months in the vast majority of patients. And then you want to stress the ligament. Now, if it's in the knee, that's very easy to do. You can do, for example, an ACL stress test or an MCL stress test with ultrasound. You can do that in the office very quickly and see whether or not the ligament healed. So you want to stress the ligament, see if it's allowing too much motion. For CCI patients, that means a digital motion x-ray. That means upright MRI flexion extension. They've still got symptoms. We believe that their upper neck was injured. And now we have to stress the ligament to make sure it's doing what it's supposed to, because ligaments, their job is to keep things from moving too much. So then the question becomes, is it moving too much, or is it allowing too much motion? JS, hi Dr. Centeno, Regenerative Clinics treats 3 through 7 with PRP. Will ligaments scar the same as it would with stem cell treatment? Yeah, the ligaments with PRP or with stem cells aren't really scarring. The treatment and the healing mechanism is not through the scar side. Realize that scar happens when things can't fully heal on their own and you get disorganized tissue that's laid down. So that's really what a scar is. A regen med procedure lays down new healthy ligament tissue based on the existing research. So that's different than a scar. And neither one of those, PRP or bone marrow concentrate, will cause or heal through a scar. Human being. My PT has me wearing a soft collar when I sleep, so I'd assume I'm not carrying a load in the cervical spine or CCJ. Would this promote healing the ligaments? Yeah, I think if you're going to try to use a cervical collar to help you heal your ligaments, using one at night is not a bad idea. Just make sure, though, that it's not causing a loss of range of motion. That is so key, because what I see is that patients that use too much of a cervical collar, they start to get very tight. They can't move their neck. Or I see patients in AO chiropractic and upper cervical chiropractic, they're told not to look, or they learn not to look or move, because then things go out and they need another appointment. But that leads to decreased range of motion. If you develop decreased range of motion because of those things, using a collar or AO or upper cervical chiropractic, then you're going to be in a world now of two problems, right? Upper cervical instability plus decreased range of motion. Both of those are problems that then need to be fixed. So I think what your PT is talking about is probably the best possible way to use a collar. Just make sure that it's not resulting in decreased range of motion of your neck. What common mistakes after injury do people make that prevents healing of partial ligament tears? I think it's what we talked about before, Vera, which is basically that they're not threading the needle, right? They don't understand that they've got to balance loading the ligament and activity with, on the other hand, making sure that you don't kiss it off, if you will. The other things that you can do would be to try to make sure that you get rid of the chronic inflammation in your system, or systemic inflammation. That's diet, that's exercise. You've got to keep those inflammatory markers low. And then you want to make sure to protect it, right? You don't want to be that person that slips on the sidewalk because you kind of forgot there could be ice out there. You kind of knew there could have been ice out there, but you didn't think about it. So those are sort of the different things. Well, thank you, Natasha. I appreciate all the hearts and the love. Right back at you. Robert, this is so far my favorite presentation. Well, great, Robert. Thank you. I appreciate that. I appreciate you and all of your help and service to the CCI community. I'm in gratitude for that. Casey, old timers teaching Prolo say you only need to treat one ligament attachment points and not the mid substance. What do you say? Yeah, I don't think that that's accurate, but I think if, let's go backwards a little bit, right? Let's unpack that. So old time prolotherapy guys, right? You really don't have any guidance. So you have to aim for the bone, because the bone is your safe zone. So if you're injecting the neck, you want to land on the facets, you want to land on the lamina within a certain distance that you're kind of estimating in your head based on the thickness of the patient. So in heavier patients, more distance, and lighter patients, less distance. But if you don't feel bone, then you're in trouble. You could have slipped into the spinal canal. You could have slipped past the side and gone off the side. So that mantra, because imaging guidance wasn't available, translates into you only inject the ligament where it attaches to bone, but not in the mid-substance because you just can't do it. It's too dangerous. So that's not because ligaments wouldn't do better if injected in the mid-substance. It's simply because you're trying to stay safe, and you stay safe with blind prolotherapy, which is prolotherapy without guidance. You're just sort of palpating and hoping to hit a bone by hitting the bone. And that's not in the mid-substance of the ligament. That's at the end of the ligament. FMG, Hit External Family Doctor from Canada here, planning to do ISMM fellowship and then applying to your fellowship program. Both passionate about orthobiologics and heard you're the best. Well, thank you so much, FMG. Yeah, we have an active fellowship program. I don't know that most people understand that or know that. We've had it now for quite some time. We've educated dozens of fellows who are out in practice. Some of them stayed with us. Most of them went elsewhere. Many of them are leaders in the field now. And so we're dedicated to teaching young physicians how to do all this stuff because it's the right thing to do. Our fellows come out at a much higher level of education than the vast majority of people who've sort of learned this stuff through the back door. And what I mean through the back door is just courses and coursework on weekends and all of that. So thank you for the shout out. RUV. Can I have instability without pain, rotational issues only affecting my vagus nerve? Sure, it's possible. Now, the hard part comes when we use some of those circumstantial components like pain in this area, or like neck pain in general, or headaches caused by the upper neck as ways to confirm that the neck is involved. But is it possible not to have much neck pain, have instability, and get vagus nerve irritation? It is. It just makes the diagnosis a little harder because we're missing some of those circumstantial evidence pieces that help us put the puzzle together. Kelly, any doctors near Tennessee who use your technique? Kelly, it depends on what you're asking about. If what you're asking about is sort of advanced cervical posterior injections, and that's going to be, basically from C23 down, then you should look at the Regenix network and see who is in Tennessee. When it comes to other things we're talking about, injecting the high upper cervical spine or the PICL procedure, no, there's no doctors in Tennessee who I would state are qualified to do that. And what I mean by qualified is that you inject the upper cervical spine as a major part of your practice. The reason why I'm talking about that is because it's an area that can be done very safely with a certain complication rate that's well below surgery. But if you don't do it all day, every day, and don't have a lot of experience in doing it, you're going to, or not that you're going to risk getting into trouble. And getting into trouble in the upper cervical spine can be catastrophic for the patient. FMG, I'd love to chat with you if you'd be open to a brief 15-minute call, your earliest convenience. Yeah, I think the best thing to do there would be just to reach out to me at my office email. I'm going to put my office email here in the comments, as I've done lots before. Okay, Centeno office at Centeno-Schultz.com. That'll go into the comments. And so just look in the comments wherever you are, it should be there. Just send me an email and I'll have Anna, my assistant, try to book a 15, 20-minute phone call where we can kind of catch up. I'd welcome that. JS, if you try to heal ligaments on your own, Does ligament scar the same as with PAICL? Yeah, again, JS, I think you're kind of off on the wrong track there, right? Regenerative medicine treatments based on the research we have don't heal through scarring. They heal through at least PRP and bone marrow, or bone marrow mesenchymal stem cells, heal through basically another bite at the healing apple. When you don't heal fully initially, then you get into scar formation, which is kind of what we were talking about before. So two different things there. Nikki, when a video consultation is approved, does that mean that CCI is seen on the images? So yeah, Nikki, if you're talking about for my schedule, then yes, that means that I reviewed the images, and I don't know when this is going to stop because it takes a lot of time, but I'm the only one doing those pre-screens right now. So it means I've looked at all of those images. And if you've been approved to get on my schedule, then I see CCI. Now, is it possible to be in another category? It is. So if I am not sure if there's CCI or additional imaging is needed, then I will tell ISIS that and NILEA, and they can then go and talk to the patient. But that means that the patient's not going on my schedule until we can confirm that at least on imaging, it looks like CCI. Lori, after 2 stem cell treatments, ligaments and x-ray showed healed and stable, still threading needle after 9 months of strengthening with Todd Ball. Thank you. Well, great, Lori. So wonderful to heal. I think you're bringing up exactly what I was talking about before, in that you want to thread that needle, right? You want to get between having some loading, but not pissing it off. So that sounds like you're on the right track there. I think I already asked that one. Or I'm sorry, answered that one. D07, what structures in CCI contribute to vision issues? Yeah, so I've got multiple videos on that, but in summary, it's the hypercervical spine that provides information to the brain about head and neck position and visual tracking. So when you injure something in the upper cervical spine, you get abnormal input to the eyes in coordination with the head and neck. And that then can lead to vision issues. So vision issues will be very common in CCI patients because of that mechanism. E. Smith, can orthobiologics treat a ligament that is healed in a stretched position, a ligament that has healed longer and looser than it's supposed to be? Yeah, so that's in general the whole point, right? When a ligament has healed, or really not fully healed, because if it was fully healed, it wouldn't be in a stretched position anymore. That's where regenerative medicine treatments come in, to give another bite at that healing apple. So yes, the answer to that is that we can, through regenerative medicine, promote healing in the ligament. Now, maybe it's not enough. Maybe it never fully heals. But usually, based on my clinical experience, it does. Old student. I have an interesting case. Did an almost complete tear of the ACL, but managed to do a full recovery without surgery. Injury to a tug of war game, 2002, 38 years old. Yeah, well, one of the things we're starting to find is that with ACL injuries, we used to think there was zero capacity for the ligament to heal. Turns out that that's not accurate. If we look at some of the European studies where they've delayed surgery, people fall into two camps. They fall, one camp is it really does heal on its own with good rehab. The other camp is it remains unstable. The person remains functionally disabled from doing what they want to do. And then those get surgery. So it's caused the entire European system to push surgery out compared to the US system, where surgery is done very, very quickly. So that's wonderful to hear that you're in that camp or that group of patients that can heal the ACL and then, you know, have a stable knee and move on and continue to do things without surgery. D07, does CCI contribute to hand weakness? Yes, CCI can contribute to hand weakness, but through other mechanisms usually. And what I mean by that is you get craniocervical instability, and let's say you start getting a lot of tightness in the scalenes because those scalenes act as like guy wires on a sailboat mast, or what are called the shrouds on a sailboat mast. And they then start getting tight. Then the brachial plexus, as it passes through the scalene, starts getting irritated, and then you start getting numbness in the hand. That's one mechanism. Or in some patients, there's a coexisting lower neck issue with the upper neck issue that's made worse by the upper neck issue, and then you start getting weakness in the hand. So those are usually the kinds of things that happen. Hajar, what do you think about prolotherapy for CCI? Yeah, when it comes to prolotherapy, it all really depends on what it is you're talking about treating. So for example, for a type 3A, someone else brought that up before, so a C2-3 anterolisthesis, so you look down and C2 moves forward on C3, then prolotherapy works really well for that. For a type 3B, where C2 is going backwards on C3, you would have to get to the anterior longitudinal ligament. That's well above the head of any prolotherapist out there, and you would have to come from like a PICL approach. So it's not going to work for that. So it just depends on the type. So the diagnosis should be type based on what ligaments are involved determines treatment. So for a type 3A, thumbs up, prolo will probably work. For a type 3B, thumbs down. For a type 2B, that's another internal alar ligament issue, thumbs down. So it just depends on what kind of type of ligament issue you have. Does PICL healing continue to happen after 4 months for young, healthy patients? The answer is yes, it does, but it depends, right? If you're a young, healthy person, then by 4 months, you've seen, let's say, 80–85% of your ligament healing. Now, you'll still get another 15% over time, but we kind of then know where the trajectory is. Usually by the 3-month mark is when we look, but certainly by the 4-month mark, we know where that's going to go, and we can say, yes, you'll need another procedure, or no, you won't. Dr. C, this is Dr. Roberts in Oklahoma. Any information on having to adjust PRP doses for patients with skin conditions such as psoriasis? I've never seen any information that would require to do that. Now, I think one concern would be, is the patient's on a biologic, then you are concerned for a couple of reasons, right? One is you've got to counsel the patient that there's a higher risk of infection with PRP. Good news is that PRP itself is antibacterial. The other thing you need to counsel the patient on is the biologic itself may reduce the healing cascade, that initial inflammatory healing cascade and/or remodeling. So the results might be suboptimal. So those are the kinds of things I would be thinking about. Now, as far as adjusting the dose, obviously in an older patient, you're going to go high dose anyway. So what do I mean by high dose? If, let's say, you have a 55-year-old patient with psoriasis, you're not going to use a kit that gives you a 2 or 3 or 5, even 5x concentration over baseline. You're going to need to be at least 10 to 20x over baseline to maximize those results. So that's really age dependent. And it's critical to adjust dose based on age, based on our published research and that of others. Okay, I think this is my last question, guys, because I'm only can do this for an hour today. My son is coming for treatment in September. He wears a cervical collar 24 hours to help with stability. He's been diagnosed with CCI between 1 and 2. Just wondering if he should take the collar off a bit each day before he comes to help with muscles. Yeah, generally, Jason, if patients are dependent on the cervical collar when we see them, we don't try to wean it before. We'll try to wean it at some point after, simply because we want to make sure that there's another bite at the healing apple. And if we're concerned about loading, then as they feel better, they can start to take the collar off to get that loading onto the ligament. So at the end of the day, I wouldn't generally do it for that kind of patient before. I would do it after the procedure. Okay, guys, well, thank you so much. I really appreciate you all being here, and it's been wonderful to spend this hour with you. I'm in gratitude that you spend it with me. And thanks for all the great questions. I will be back next week. And although I may not be able to do next week, I think I'll be traveling. So we may have to take a week off there. Just give me a heads up, but I'll let you know. Thanks so much, and have a great day.